people were really destined to disability or death, and there was really no interest or apparently any prospects in effective treatment. And we've gone to the situation now where we have highly effective but urgent therapies for stroke, and it's really been exciting to be along for the ride. So what I'm going to do is tell you about 3 threads of research that I have been involved with over this period of time. The first being intravenous alteplase, a tissue plasminogen activator for acute ischemic stroke, which was a long time coming into clinical practice and has been really difficult to implement. The second, the amazing story of the success of endovascular clot retrieval for large vessel occlusion. And again, there were many hiccups from the beginning of this story. This is really a triumph of technology that I'll tell you about. And we've been very successful in implementing this in Victoria. And finally, at the other end of stroke, looking at ways to improve outcome, the story of testing early mobilisation, early rehabilitation after stroke. And this is an example of a promising intervention that didn't turn out. So the idea has always been behind acute therapies that we need to restore blood flow to prevent tissue death. And the notion of using a thrombolytic agent to recanalise arteries goes back to early publication in 1958 actually from the US of just trying intra-arterial plasmin in 3 patients and showing that it might help. It was much easier to do this kind of research then. And then it was not until 1988 that the landmark GISI-1 streptokinase trial in acute myocardial infarction was published, and this approach was rapidly introduced into clinical practice. And there was work then on the stroke side to see if this could be translated for stroke care. And in the late 1980s, there was work both with an Italian focus with the MAST I&E trials, but extremely importantly for the history of stroke in Australia, the Australian streptokinase trial testing intravenous streptokinase, the results of which were published in JAMA in 1988. And this was a blow for the field. It didn't show any benefit. There was a signal of harm beyond 3 hours, and of course the problem with thrombolytics of hemorrhagic transformation of ischemic stroke. Now I mention Australian streptokinase trial because this was the first ever multi-centre acute stroke trial in Australia and was the very beginnings of what has become an amazingly successful Australasian stroke trials network and a culture of really strong and effective collaboration in the field of stroke. And this was really facilitated by the establishment of the Stroke Society of Australasia in the late 1980s. This trial put Australian clinical stroke research and trials on the map. And this was my first clinical participation in research in that I was a registrar randomising patients to this trial and commencing the therapy, and unfortunately it wasn't successful. Then there was a move to find other thrombolytic therapy, the idea being a good one, that we should open the arteries. And TPA, tissue plasminogen activator, was tested in animals and looked very promising. The next few years were devoted to dose finding and some initial safety studies. And then the landmark study published in the New England Journal in 1995, the pivotal NINDS trial, testing alteplase versus placebo in acute ischemic stroke less than 3 hours from onset. And this was an effective therapy, the very first in acute ischemic stroke. It signalled the paradigm shift that we have now of stroke being an emergency, and this has become standard therapy in international guidelines. Now, in the intervening years, we have had great difficulty implementing this into practice. Back in 2007, we had NICE endorsement for this therapy, that it was effective and cost-effective. There have been several meta-analyses of a number of other randomised controlled trials that have contributed to the data, and we have level 1 evidence that alteplase is effective for acute ischemic stroke less than 4.5 hours, and the earlier we give it, the better the outcome. And in fact, it was approved for this indication by the Therapeutics Goods Administration in 2003. But sadly, even in 2015, only 7% of Australian acute ischemic stroke patients have received this therapy. So why has implementation been so suboptimal? Well, this is really a talk and a discussion in itself, so I'll have to be brief. But this is a very complex, time-critical intervention. It requires alignment of behaviours and collaboration between ambulance, ED physicians. It requires organisational support and systems of care. There's a need to recognise the condition in the community and the need for urgent attention. Clinical diagnosis can be challenging. You need rapid brain imaging to confirm eligibility. There's concern about things that make you likely to bleed with this thrombolytic therapy. And the drug itself is a beast to administer. It's hard to draw up. You give it as a bolus and an infusion. And there's also been a complex and difficult discussion about how to explain the benefits of this therapy that do come at a small but definite risk of severe and fatal intracerebral hemorrhage. So what has worked? And there have been two interventions in Australia that have been highly successful. The first being the Victorian Telemedicine project. And this work has been a large collaborative, but run, co-chaired by Professors Chris Bladen and Dominic Cadillac, both associated with Monash University and the Florey. And the aim of this was to implement a stroke telemedicine program in regional emergency departments to try and increase stroke thrombolysis. The idea that you're in a regional hospital, the ED staff can call a 1300 hotline that puts you straight in contact with a Melbourne-based stroke neurologist who has direct access to imaging and can perform a telemedicine consultation. And this is now operative across 16 hospitals across Victoria and has resulted in a profound reduction in the processes that are needed to deliver thrombolysis, and has raised the thrombolysis rate in these centres to a remarkable 25% of patients with acute ischemic stroke arriving within 4.5 hours. In compared to the state average of 7%, the Australian average of 7% overall. Another fantastic example of how there are ways to help with implementation into practice has been the establishment of the Australian Stroke Clinical Registry, or OSCAR. And this has allowed centres who participate to benchmark their performance with key stroke indicators and review this over time and see how one compares with other centres. And over the period from 2012 to 2014, you'll see that there have been improvements in a number of parameters, but notably a 10% improvement in the odds of patients receiving thrombolysis in participating centres. Moving on now to what has been the miracle treatment of the last century in stroke. And this is the notion of pulling out clot from blocked arteries. And really, this is looking to other fields for inspiration and seeing the success of endovascular therapy in coronary arteries. And this again goes back to the early 1980s, where there were first reports of intra-arterial thrombolytics in stroke, and then publication of trials of thrombolytic agents in the late 1990s. Notably, the PROACT and PROACT-2 trial showing that there was a remarkable improvement in recanalisation rates of arteries, but this was in comparison to historical controls rather than a randomised controlled trial, and didn't go further into practice. There was time spent looking at whether you could give intravenous thrombolytics and then convert to intra-arterial therapies, and also some testing of angioplastic approaches that have been used in cardiology, where stabilising ruptured plaque is an important part of the treatment. But around this time, there became a clear recognition that, in fact, most large artery strokes are due to emboli from more proximal sources. So here you can see an occlusion of the left proximal middle cerebral artery. And the problem in stroke is usually the need to remove a clot from normal or near normal arteries rather than plaque stabilisation. So then the race was on to try and find a way to do that. And we had setbacks. In 2013, the first 3 trials of endovascular therapy versus standard care were published, and these were all negative, and we were very sad. But never give up, because this was always a very good idea, and we learnt many lessons: that it was important to treat people early, that if we put people into these trials, they actually had to have a vessel occlusion to benefit from having a clot removed. And the real triumph was the advent of better devices. We started out with these clunky devices that had corkscrews in the end and suckers and all sorts of things. And in fact, the great advance was serendipitous, as so many things in history. The bottom picture there is of the so-called stent retriever. And this was a device that was actually developed to help endovascular therapists to manage unclipped aneurysms and was noted to collect clot and pull it out. So people tried it. And now this is the type of device that's used to open arteries in stroke. Then this was our hallelujah moment, really, of my entire career, when there were 5 positive randomised controlled trials of this approach to pulling out clot in blocked arteries in stroke. And very importantly for us, Extend-IA, a Melbourne-based trial collaborating across Australia, led by Bruce Campbell and Peter Mitchell, but involving many people around Australia. And this showed an extraordinary benefit, a treatment benefit from this approach compared to IMS3, which was using the old paradigm, and a consistent effect, although the absolute effect varied across the trials and really was a reflection of better recanalisation of arteries, faster treatment, and also the use of advanced imaging to try and select patients who had tissue at risk that was yet to infarct. So what I think has been a great success of Translation in Victoria has been the rapid implementation of this therapy in Victoria. And this was facilitated by the existence of the Victorian Stroke Clinical Network within the Department of Human Services and Health and Human Services. And this had been bringing together local clinical leaders in a multidisciplinary group for some time who had awareness of this work and immediate awareness of results. And there's been a clinician-driven approach to rational implementation with development of a statewide protocol with designated statewide service providers, initially Royal Melbourne Hospital and from tomorrow Monash Health, and with engagement of all the stakeholders and consideration of new funding approaches. And this has been supported by the existing Victorian stroke telemedicine infrastructure so that this therapy is also available to regional Victoria. A great win of translation into practice in Victoria. And finally, for the last few minutes, I want to tell you about a third string of research that I've been involved with, this time looking at how to better improve outcome after the stroke has occurred and acute therapy has done its best. An AVERT, or a trial of very early mobilisation after stroke, has been a very long time coming. We've known for decades that bed rest is bad for people who are ill and that there are many complications that occur, pulmonary emboli, aspiration pneumonia, loss of muscle and other conditioning. And the exploratory work to develop what became a large randomised controlled trial goes back to 2002 with some very detailed observational work across stroke units around the world, which told us, which perhaps what we knew but didn't at the time, that patients in hospital were extremely immobile and spent most of their time in bed. And there was also around this time increasing evidence that for physical recovery, more practice resulted in better outcome. So the simple question arose, what if we could get people up and moving and out of bed earlier after stroke? Would it be better? And some people thought it would be harmful. There was then the development of a phase 2 study that had a few less than 100 patients in it, and mobilisation improving outcomes. It looked clearly effective, it looked cost effective, and we're so excited to develop the phase 3 large randomised controlled trial. Some people were completely persuaded by this early data, and early rehabilitation started to be included in clinical guidelines. The trial took a long time to complete, from July 2006 to October 2014. It was a massive success of collaboration internationally with 56 sites from 5 countries, led from Melbourne, more than 1,000 clinical staff, An interesting statistic, more than 180 babies were born to staff members in the trial over the course of the trial. It recruited more than 2,000 patients. Follow-up was great. Everyone thought it was going to have a fabulous result, and the primary outcome was published in The Lancet. However, this was an example of where the outcome was not what was expected. And what we found was that just to orientate you to this very stroke-specific way of looking at outcome, MRS is the modified Rankin scale. 0 is no symptoms, perfectly well, 6 is dead. And we look at how many people have a Rankin of 0 to 1, or 0 to 2 in fact, and you can see quite clearly that the patients who received usual care did better. This was a great blow, and now we have to find ways to remove the blanket recommendation for early mobilisation from clinical guidelines and decide what we should do. So, I know this has been a very rapid Cook's tour, and it doesn't do justice to all the work that went into this, but I'm hoping that I've illustrated how exciting clinical research can be. We started in a field where there was nothing, and now we have effective therapies, and we have systems and collaborations that mean that we can do large randomised controlled trials led from Australia. Results can be unexpected, progress is non-linear, and importantly, successes in other diseases are very important to inform our research and to help us think outside our own box, but they don't always translate. It's actually very difficult to change clinical practice, which is what we've seen with the failure to implement intravenous thrombolysis, but not always, as we've shown with endovascular clot retrieval. Clinical observations are a first step, and the collaboration and research networks that we have developed in Australia are essential and really a key to our success. So before I finish, I just want to acknowledge that the slide from AVERT and the slides about the VST network were provided by my colleagues Dominique Cadillac and Julie Bernhardt, and just to acknowledge that a very large number of people across Australia have contributed to those outcomes that I've shown you today. Thank you very much.